Usually when we talk about a medical diagnosis, there is this expectation of precision.
Right, it's almost like engineering.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, there it is.
Yeah, very black and white.
But suddenly that x-ray machine is completely broken when we step into the diagnostic landscape of sexual health, neurobiology, and postpartum recovery.
Oh, for sure. We are looking at incredibly murky waters here.
Very murky.
Oh.
Especially when we look at how the neurochemical effects of daily antidepressants are secretly colliding with the physical reality of vaginal laxity.
It is, honestly, the absolute definition of diagnostic muddy waters.
Right.
Because we're dealing with systems that overlap in ways modern medicine is only, just starting to acknowledge out loud.
Which is crazy to think about.
It really is. I mean, when you take a systemic medication, it doesn't just stay in your brain. It travels everywhere.
Which is exactly what we are unpacking today.
Yeah.
Millions of people take antidepressants to improve their quality of life.
And they are absolute lifesavers, true.
Lifesavers, yes. But a lot of those same people are walking around with these invisible, profoundly disruptive sexual side effects that, honestly, no one warned them about.
They suffer in complete silence.
Right. And if you are listening right now, whether you are navigating these medications yourself, maybe you're researching postpartum health, or you just are insanely curious about the wild mechanics of the mind-body connection, this deep dive is going to give you a completely new lens.
A totally new understanding of how human anatomy and neurochemistry interact.
Yes. So let's just get into it.
Yeah, and to really ground this conversation, we have to look past the classic low libido that people might, just assume comes with being depressed.
Right, because everyone just thinks, oh, you're depressed, of course you have low libido.
Exactly. But today's deep dive isn't just about libido. We are specifically looking at physical sensation.
Sensation itself.
Yes. We're looking at how the chemical numbing caused by selective serotonin reuptake inhibitors, SSRIs, can actively make the physical, structural symptoms of vaginal laxity feel astronomically worse.
It's the literal intersection of tissue integrity and neurochemistry.
It really is.
So let's start with the chemical muting of sensation, because the clinical data on this is, frankly, staggering.
The numbers are huge.
Yeah. The sources say anywhere from 30% to 80% of people on SSRIs experience sexual side effects.
80%.
80%. That is a massive portion of the population. We all vaguely know SSRIs increase serotonin to help with mood. But how does that actually result in physical numbing?
Well, it comes down to the nervous system being an incredibly delicate balancing act.
Okay.
SSRIs are designed to keep serotonin in the brain's synapses for longer, which is fantastic for regulating mood, blunting panic, and reducing anxiety.
Right. That's what we want them to do.
Exactly. But the brain operates on a seesaw mechanism.
A seesaw.
Yeah. When you saturate specific subreceptors, particularly the 5-HT2 and 5-HT3 receptors, with all that excess serotonin, it triggers a downstream effect.
Okay. What does that effect do?
It actively suppresses the release of dopamine.
So we are artificially holding the seesaw down on one side. Serotonin goes way up, so dopamine gets crushed.
Precisely. And dopamine is the fuel for sexual motivation.
Right, the reward center.
Yeah, the physical perception of reward. When dopamine flatlines, the desire circuitry basically just shuts off.
Wow.
But it goes way beyond just psychological desire. That same serotonin overload disrupts your nitric oxide pathways.
Wait, nitric oxide, like what they talk about in heart health.
Exactly the same stuff.
Yeah.
Nitric oxide is the essential chemical messenger that tells your blood vessels to dilate and open up.
Oh, I see. So I'm guessing without nitric oxide, you aren't getting the necessary localized blood flow down to the pelvic region.
None. The vessels stay completely constricted. And without that engorgement, physical arousal becomes mechanically incredibly difficult, if not impossible. The tissue literally isn't getting the oxygen and blood volume it needs to become sensitive to touch.
Which brings us to a phenomena that genuinely shocked me when I was looking through these psychiatric reviews.
The genital anesthesia effect.
Yes, genital anesthesia. We aren't just talking about a lack of interest here. We are talking about literal physical numbness in the genitals.
It's a severe reduction in tactile and erogenous sensation.
And researchers note it can sometimes happen within 30 minutes of taking the very first pill.
Yeah.
30 minutes. That's insane.
It is a profound physiological shift. Patients often describe it to their doctors as feeling like they've been given a topical anesthetic.
Like Novocaine at the dentist.
Exactly like Novocaine. Touch registers on a basic, pressure level.
Like you're being touched.
Right, but it carries absolutely no sexual or pleasurable charge. The nerve endings are essentially chemically muted.
Okay, but let me push back on this a little bit, because if you're sitting in a doctor's office, I can hear the counter-argument already.
Oh, I know what you're going to say.
Right. Because depression itself causes a massive drop in libido and pleasure. It makes you feel disconnected, fatigued, physically heavy.
Yeah, depression is heavy.
So how can a clinician definitively say, yes, it's the medication causing this localized numbness, and not just the heavy numbing weight of the depression itself?
That is the exact trap many practitioners fall into.
Oh, absolutely.
Which unfortunately leads to a lot of patient dismissal.
It's all in your head, that kind of thing.
Exactly.
Mm.
But the clinical differentiator here is the timeline. It's all about chronobiology.
Okay, break that down for me.
Sexual side effects from SSRIs typically emerge within 1 to 3 weeks of starting the medication, or even just increasing a dose.
Okay.
And this happens well before the antidepressant benefits actually kick in, because those usually take a solid 2 to 4 weeks of neurogenesis in the brain. Ah, okay. So the physical numbness arrives before the mood actually improves. You're still depressed, but suddenly you're also numb.
Yes, the timing is a dead giveaway. Furthermore, untreated depression usually affects the psychological desire for intimacy.
Like you just don't have the energy or interest.
Right. But the medication, on the other hand, profoundly affects the mechanical, physiological processes.
The arousal, the physical ability to trigger an orgasm, the actual tactile sensation.
Exactly. You might actually want to be intimate, but your body physically refuses to respond.
That sounds incredibly frustrating. And for a subset of people, this doesn't just magically resolve when they eventually taper off the medication, does it?
No, it doesn't. There's a condition called post-SSRI sexual dysfunction, or PSSD.
PSSD.
Yeah. It is one of the most challenging frontiers in modern psychiatry.
Because it just doesn't go away.
Right. It's a condition where this genital anesthesia and loss of sensation persists for months, years, or sometimes indefinitely.
Indefinitely.
Yes, even after the patient has completely cleared the drug from their system. That is a very heavy word, indefinitely. I mean, how does a drug that is completely out of your system still mute your nerves?
Well, the defining hallmark of PSSD is this enduring change in sensation that lasts well beyond the typical 3-month withdrawal window.
Okay.
Clinicians and researchers believe this involves long-lasting epigenetic changes.
Epigenetic, like changing your DNA.
Kind of. Think of your DNA like a massive soundboard.
Okay, I like that analogy.
The SSRI doesn't change the actual sliders on the soundboard, but it might permanently flip a mute switch on certain genetic expressions.
Wow.
There's also this theory of persistent receptor desensitization.
Which means what exactly?
The receptors literally retreat into the cell membrane to hide from that initial serotonin flood.
Oh, to protect themselves.
Right. But in some patients, they seemingly forget how to come back out to the surface.
That is deeply sobering.
It really is.
But to really understand why this chemical muting is so devastating to a person's overall quality of life, we have to look at the other half of this collision.
Right, the mechanical side.
Yes, the physical mechanics of sensation. Because sensation doesn't just happen in a vacuum. It requires a physical structure.
Exactly.
Which brings us to vaginal laxity.
Yes. So we've established the chemical side, so now we transition to the structural side.
Let's define it. What is it physically?
Vaginal laxity is clinically defined as a structural alteration. It's a feeling of looseness or a distinct loss of physical tension in the vaginal walls.
And just to be clear on the anatomy here, this happens because of weakened muscles, right? Like the pelvic floor just gives out.
Well, the muscles are a big part of it, specifically the levator ani muscles.
The levator ani.
Yeah, they act as the main support hammock of the pelvic floor. But it's actually much more about the cellular matrix.
Meaning the tissue itself.
Yes. It's the degradation of type I and type 3 collagen fibers within the vaginal mucosal walls.
Yeah, the collagen.
Those collagen fibers are the architectural scaffolding that gives the tissue its elasticity, its tightness, and its bounce.
So when they are overstretched or chemically degraded, the tissue literally loses its structural integrity.
Exactly. It just doesn't snap back.
And looking at the urogynecology data, this is incredibly common, right?
Extremely common.
It's frequently the result of vaginal childbirth, especially if there were multiple births, or tearing and trauma during delivery.
Oh, absolutely.
But it's also caused by natural aging and the sharp drop in estrogen that happens during menopause or even breastfeeding.
Estrogen is key here. It acts like a maintenance crew for that collagen scaffolding.
Okay.
When estrogen drops, the maintenance crew essentially goes home and the collagen breaks down.
Wow. and the prevalence is staggering. I saw in the sources that 58% of first-time mothers report some form of sexual dysfunction a year after childbirth,
58%.
over half. And laxity is a primary complaint.
It's a massive demographic experiencing a fundamental structural change in their physical anatomy.
And yet they are often told it's just, part of having a baby.
Yeah, just learn to live with it. It's
Yeah.
incredibly dismissive.
I want to clarify something here for you guys listening, because medical terminology can get really dense and intimidating.
It definitely can.
People often confuse vaginal laxity with pelvic organ prolapse.
Yes, very common mix-up.
But understanding the difference is crucial to understanding the loss of sensation. So think of it like this.
Okay.
If your pelvic floor is a hammock tied between two trees, vaginal laxity is when the hammock's fabric gets permanently stretched out.
Right. It loses its bounce.
It's a bit saggy. The threads, which are the collagen fibers, are worn down.
Exactly.
But pelvic organ prolapse is when the actual trees holding the hammock start falling over, causing the bladder or uterus to physically drop down into the vaginal canal.
That analogy perfectly separates the two conditions. And what's fascinating here is that it highlights why laxity specifically targets sensation.
Because of the fabric.
Right. When that hammock fabric is stretched out, when the vaginal canal is widened and the tissue elasticity is gone, you have a direct mathematical loss of physical friction during intimacy.
Less friction means less physical stimulation to the nerve endings.
Sensation fundamentally relies on contact.
Right.
If the structural integrity of the walls is compromised, the mechanical input, the actual physical friction, is drastically reduced before the signal even tries to travel to the brain.
Okay, so this brings us to the convergence, the core aha moment of this deep dive.
Yes, the intersection.
The big question. Can antidepressants actively make laxity feel worse through reduced sensation?
If we synthesize what we know about how these two systems interact in the human body, absolutely.
Compound each other.
In a truly devastating feedback loop, physical pleasure relies on a continuous loop between the mechanical input of the body and the neurological processing of the brain.
Okay, so laxity breaks the mechanical side.
Exactly. Vaginal laxity breaks the mechanical side of that loop. Because the canal is wider and the collagen is degraded, there is less physical friction.
Which means a significantly weaker physical signal is being sent to the nerves in the first place.
The mechanical volume is turned way down.
Barely a whisper.
Meanwhile, the SSRIs break the neurological side of the loop.
Because of the numbing.
Right. The serotonin overload and the dopamine suppression literally numb the nerves themselves.
So you have nerve endings that are chemically incapacitated, trying to receive a mechanical signal that is already severely weakened by the laxity.
It's a double block.
Here's where it gets really interesting. Think about it like trying to read Braille.
Oh, this is a great way to picture it.
Vaginal laxity means the Braille bumps on the page have been worn down and flattened.
They're physically harder to feel.
Right. And taking an SSRI is like putting on a pair of thick winter gloves.
Yes. And if we take that Braille metaphor a step further, the brain eventually stops even trying to read the page.
Because it's not getting anything.
Exactly. If you have flattened Braille and you're wearing thick winter gloves, your chances of feeling anything at all are basically zero.
Zero. The physical structure isn't providing the input, and the chemical state of your nerves is preventing any reception.
It's a complete shutdown of the sensory pathway.
And the psychological impact of this double blow is just heartbreaking.
It really is devastating for quality of life.
If you're listening to this and you've ever felt like your body was failing you, think about the new mother navigating postpartum depression.
Such a common scenario.
She's rightfully prescribed an SSRI to help her survive a really dark time, which is entirely appropriate for her mental health.
We need to manage the depression, absolutely.
But she's also dealing with the physical aftermath of childbirth, the laxity, the drop in estrogen. She attempts intimacy, and she feels absolutely nothing.
And because her doctor never warned her about the genital anesthesia effect of her medication, she mistakenly blames her postpartum body entirely.
She internalizes the loss of sensation as a permanent failure of her own anatomy.
She looks in the mirror and thinks she is broken.
Yeah.
She has no idea that her daily depression medication is actively putting thick winter gloves over her already compromised, flattened nerve receptors.
Which creates this brutal cycle of frustration, avoidance of intimacy, and paradoxically, often deeper depression.
It's a terrible cycle to be caught in.
So how do we untangle this knot?
Well, We have to look at the treatments.
Because you clearly can't treat overstretched collagen by switching your anxiety medication.
Definitely not.
And you can't cure SSRI-induced nerve numbing by doing Kegel exercises.
No, you can't fix the gloves by fixing the braille. That is the most crucial takeaway for any patient or clinician dealing with this.
You have to separate them.
Because you are dealing with two entirely different biological systems, one structural and one chemical, they require entirely distinct parallel medical interventions.
You have to treat both pathways simultaneously.
Exactly.
Okay, let's break down the structural fixes first.
Okay.
Fixing the flattened braille. The clinical guidelines outline a few distinct pathways, right? The historical gold standard for the muscle weakness aspect is pelvic floor muscle training.
Yes, often guided by a urogynecological physiotherapist.
This is about consciously rebuilding the strength of the levator ani muscles.
But as modern urogynecology points out, voluntary exercises like Kegels have severe limitations.
They aren't enough on their own.
No, they can't always restore severely stretched tissue, and they certainly cannot regenerate collagen on their own.
Which is where advanced biophysical interventions come into play.
Right. We are seeing incredible results with the technologies like high-intensity focused electromagnetic stimulation.
Those are often seen as LiPo 360 EMS chairs, right?
Yes, the MS chairs.
So this goes beyond just, clenching a muscle.
Yeah.
How does a magnetic chair fix laxity?
Well, you sit fully clothed on a specialized chair, and it uses a focused electromagnetic field to bypass your brain's motor neurons.
Okay.
It forces the pelvic floor muscles into what are called supramaximal contractions.
Supermax.
Yeah. These are contractions that are vastly more intense, rapid, and complete than anything you could ever achieve voluntarily.
Oh.
We're talking thousands of perfect maximal contractions in a 30-minute session.
That's wild.
It is. It forces dormant muscle fibers to reactivate and physically thickens the muscle bundles, which helps narrow the canal.
Okay, and for the mucosal tissue itself, the actual walls of the vagina where the collagen has degraded, we're seeing thermal radiofrequency and laser treatments in the sources.
Those are very effective for the tissue level.
These devices deliver highly controlled heat into the submucosal layers, which triggers a biological response called neocollagenesis.
Yes, neocollagenesis.
Yeah.
It is essentially the body's repair mechanism kicking into overdrive.
How does heat do that?
The localized heat, usually around 40 to 45 degrees Celsius, tricks the local tissue into thinking there's a mild injury.
Ah, okay.
This causes the existing stretched-out collagen fibers to instantly contract and tighten.
Instant tightening.
But more importantly, brings fibroblasts rushing to the area.
Fibroblasts. Those are the cells that spin new collagen, right?
Exactly. They start laying down brand new, tightly woven type I and type 3 collagen.
So it rebuilds the scaffolding.
Yes. This restores the actual structural elasticity of the tissue itself, narrowing the canal and bringing back that crucial mechanical friction.
Okay, so that addresses the structural side. We fixed the flattened braille.
Right.
But what about the thick winter gloves? How do you safely fix the chemical side of this without pulling the rug out from under the person's mental health?
This is a critical safety point.
Because the underlying depression or anxiety still needs to be managed.
Exactly. And based on every psychiatric protocol, you must never stop these medications abruptly.
Never cold turkey.
No. Stopping an SSRI cold turkey can trigger severe withdrawal syndromes, brain zaps, and a highly dangerous rebound of the underlying depression.
It has to be managed by a prescriber.
Strictly managed, yes.
So what are the evidence-backed fixes that doctors actually use for the chemical side?
The first, most conservative step is dose titration, working with a prescriber to find the lowest effective dose.
Right.
Sometimes, dialing the SSRI back by just a few milligrams is enough to restore localized sensation while keeping the mood stable.
And if dose reduction isn't viable?
Switching medications is the next logical step.
But you can't just switch to another SSRI, right?
Yeah.
Because they all work on that same serotonin dopamine seesaw.
Correct. Switching from Lexapro to Zoloft often just trades one set of side effects for another.
So what's the strategy?
The strategy is switching to a medication with a completely different mechanism of action, specifically ones with little to no serotonergic impact.
Okay, like what?
Bupropion, commonly known as Wellbutrin, is the classic alternative. It primarily targets dopamine and norepinephrine.
So it bypasses the serotonin problem.
Exactly. Because it doesn't flood the system with serotonin, it largely spares the sexual pathways and doesn't cause that downstream dopamine crash.
Makes total sense.
Mirtazapine is another alternative. It blocks very specific serotonin receptors rather than flooding the entire system, resulting in significantly lower rates of sexual blunting.
But what if someone can't switch?
That happens a lot.
Right, like what if their current SSRI is the only chemical anchor keeping their head above water and they are terrified to change it,
In that case, you move to augmentation strategies.
meaning adding something else?
Adding a secondary agent to explicitly counteract the side effects of the first, PDE5 inhibitors like Viagra or Cialis are well documented to help with the physical arousal side for both men and women.
Because of the blood flow.
Right. They bypass the serotonin block by directly forcing the nitric oxide pathways open, compelling the blood vessels to dilate and restoring localized blood flow to the pelvic region.
And there was one other augmentation strategy in the clinical literature that blew my mind because it's not a synthetic pharmaceutical.
The saffron.
Yes, it's a natural supplement, saffron.
Saffron is fascinating.
The clinical data shows that a daily dose of 30 milligrams of saffron has rigorous, randomized controlled trial evidence backing it up for improving SSRI-induced sexual dysfunction in both men and women.
It is really impressive data.
But how does a spice counteract a complex synthetic neurochemical block?
Well, saffron contains active compounds like crocin and safranol.
Okay.
Researchers believe these compounds possess strong antioxidant properties that improve endothelial function.
Endothelial function,
There we go.
meaning the blood vessels.
Exactly. They help repair and protect the blood vessels, supporting that crucial nitric oxide release we talked about earlier.
Oh, wow.
Furthermore, it appears to gently modulate neurotransmitters, reducing the sexual inhibition caused by the SSRI without reversing the mood-elevating benefits.
That's incredible.
It's one of the very few non-pharmaceutical interventions with hard data supporting its use for this specific chemical numbing.
It's wild to think that the same spice used in, like, risotto is actively repairing endothelial function against synthetic neurochemicals.
Nature is pretty amazing.
So what does this all mean for you listening right now? If we step back and look at this entire landscape, the overarching message is that sexual health is a wildly complex puzzle.
It really is.
It is an intricate, constant dance between physical mechanics and delicate neurochemistry.
And it is never just in your head, and it's rarely just one simple physical issue. The body is a unified system.
And by understanding that a daily medication can chemically magnify a physical structural issue like vaginal laxity, you are suddenly empowered.
Exactly. Knowledge is power here.
You are no longer suffering in the dark thinking your body is just broken or that you're failing at being intimate.
You can go to your doctor and advocate for yourself.
You can ask for pelvic floor physiotherapy or neocollagenesis treatments for the physical side,
Yeah.
while simultaneously discussing bipropion or saffron for the chemical side.
You have the vocabulary to tackle both the braille and the gloves.
That empowerment is the ultimate goal of this deep dive. But as we wrap up, this collision of anatomy and chemistry raises an important question.
A very big question.
One that goes even beyond sexual health.
Yes, because we now know definitively that our emotional medications, these SSRIs we swallow every single morning, can profoundly and structurally alter our physical sensory experience in the pelvic region.
Right.
If a pill taken for generalized anxiety can cause literal, measurable genital anesthesia, how might these exact same daily medications be subtly rewiring our physical perception of pain, touch, or even temperature across the rest of our bodies without us ever realizing it?
Wow. That is a thought to sit with. Are we walking through our entire lives wearing invisible winter gloves?
It really makes you wonder.
Thank you for joining us on this deep dive.
Okay.
Until next time, remember that the X-ray rarely tells the whole story, and the muddy waters are exactly where the real answers are hiding.